All right, metabolic disorders. Often when I do this with the residents or in grand rounds, I do it in 1 hour. We're going to do this whole chart in 2 hours. Everybody ready? Okay. All right, we're going to do an overview of inborn errors of metabolism. We're going to talk about specific categories: intoxications, energy metabolism defects, and complex molecules. And then we're going to briefly talk about newborn screening. All right, so inborn errors of metabolism were first described by Sir Archibald Garrod in 1908, so more than 100 years ago. They're individually rare, so the likelihood that you will see any one of the things that we're going to talk about is low. However, if you see a sick, full-term newborn, about 20% of those kids will have an inborn error of metabolism. Whenever I was doing my training, this was far more mysterious. Now that we have expanded newborn screening, a lot of the mystery has been taken out of these very ill newborns, but they still do occur. They have nonspecific presenting symptoms, which is not helpful. But if you recognize what is going on, you can intervene with a special diet, avoid catabolism. Some people you can give enzyme replacements for, and some people will respond to a bone marrow transplant. The majority are autosomal recessive. So remember, in the last talk, we only did like 2 slides on autosomal recessive. This is the 2 hours of autosomal recessive disorders. So they won't have a family history, but look for consanguinity or known high-risk populations. And it's important to know the ethnic background of your patients because that could be your key and your clue to what's going on. Exceptions to the autosomal recessive. So if you can't remember and it looks metabolic, guess autosomal recessive. Here's the short list of exceptions. Things that are mitochondrially inherited due to a mutation in the mitochondrial DNA. So it'll have maternal transmission. And here's the short list of X-linked conditions: ornithine transcarbamylase, or OTC deficiency, X-linked adrenal leukodystrophy, Hunter's disease, which is also mucopolysaccharidosis type 2, Fabry's, Lesch-Nyhan, and Menkes. And then guess autosomal recessive for everything else. All right, so our categories: problems of intoxications, acute or progressive problems, and it's due to accumulation of toxic compounds. Problems of energy, so you don't have enough energy in your system. And then the complex molecules, which are disturbed synthesis or catabolism, and the symptoms are permanent and progressive. So, first third of the talk is disorders of intoxication. All right, so all of biochemistry is compound A has to be turned into compound B, which then has to be turned into compound C. When you do all of those metabolic labs, what you're looking for is a pattern. And by the pattern, you'll be able to figure out what is blocked. So if the block between B and C occurs, A will go up, and B will go up, and C will go down. So you're looking for what's up and what's down so you know what's in between, and you're looking for the pattern to be able to make the diagnosis. So categories: amino acid problems, urea cycle problems, organic acidemias, and these are small molecules generated from metabolism of amino acids, carbohydrates, and fatty acids, and then sugar intolerances. Okay, basic biochemistry. Generally, the enzyme block is in protein degradation and disposal or sugar breakdown, and it results in a buildup of keto acids or nitrogen, which is ammonia, and these are the metabolites that cause the problems. When you're catabolic or you have increased protein intake, it makes it worse. The hallmark is a period of normalcy, and then the child becomes ill. So they look just fine when they're born, and it can be hours to years before the symptoms show up. They can be acute or intermittent, or they can be insidious with developmental delay and intellectual disability. So PKU is the hallmark disorder for this insidious onset and the basis for all of our newborn screening. That by the time you recognize what's going on, it's too late to intervene. So if you know what's going on, then you can intervene with a diet. Methylmalonic acidemia, or MMA, is an organic aciduria that will present early with ketotic metabolic acidosis, and vomiting will get your attention. So you're going to see your abnormalities on screening tests in your urine organics, your plasma amino acids, plasma acylcarnitine profile, and your expanded newborn screening. So that's really been the game changer over the last 20 years, is being able to do tandem mass spec and to look for the amino acids and the acylcarnitine profile on that newborn screen. What you're not getting is the urine organics, because it's only a blood test on newborn screening. Abnormalities will be more striking if the patient is symptomatic. So some results may normalize when the child's well. So the more ill the child is, the more likely they're going to throw the abnormal metabolite that we're searching for that will help us make the diagnosis. So our goal is to identify the child before they become sick. And this is the whole basis of newborn screening. Treatment is often a dietary restriction. You remove the precursors that build up and poison the cells, and then you avoid dietary compounds that cause the problems. You would also like to avoid catabolism to decrease the rate of unrestricted protein breakdown. So every time somebody gets sick, then they're going to go into a catabolic state. So no matter how well they were doing on their diet, now we're going to get disordered metabolism based on that. All right, so we'll start with the amino acid problems. PKU, tyrosinemia, homocystinuria, maple syrup urine disease, and non-ketotic hyperglycemia. There are many, many more. However, these are the ones that you're most likely to see and most likely to see on a test. All right, so case presentation, we go to clinic. The baby was identified on newborn screening to have high phenylalanine levels, and confirmatory testing is consistent with PKU. He's growing and developing well, and you're talking to the family. The older brother is severely intellectually disabled. He has seizures, autistic features, and the brother was born in Russia. So he tests the brother and confirms that he also has PKU. So remembering that not all places do newborn screening, and what newborn screening is in your state may not be what it is in the next state. And for those of us who live near borders, when your child is born over the border in another state, you have to know what's on that newborn screen versus yours. Don't always assume that everybody's had exactly the same thing. All right, PKU is autosomal recessive. It's the most common disorder of amino acid metabolism with about a 1 in 10,000 incidence. The gene carrier frequency is about 1%, and more common in certain ethnic groups, about 1 in 4,000 in the Irish and about 1 in 500,000 in African Americans. So not impossible outside of Europe, but less common. So PKU is most usually due to deficiencies in phenylalanine hydroxylase, so this enzyme that takes phenylalanine to tyrosine. I love this condition because there's only one way to enter this pathway, and that's by eating. So phenylalanine is an essential amino acid. You have to eat it to get it. Tyrosine you can make, and you can also eat it. So these kids are normal at birth. Untreated, they will develop severe intellectual disability with IQs of less than 30, and the damage is irreversible by about 8 weeks of age. In the untreated population, we have seizures, autism, irritability, vomiting, eczema, decreased pigmentation compared to family members, and a musty odor. And that's the byproduct of the phenylacetic acid. The goal of newborn screening is to start the dietary treatment by 14 days of age. With our new expanded tandem mass spec newborn screening, this is often down to under a week now. Whenever I was in training, it often took us up to the 14 days to get all of the tests back. So what you're looking for is an elevated plasma phenylalanine, and the child is not on TPN. And it's an isolated peak. You really just have elevated Phe. On the other side is a low tyrosine because you're not converting the phenylalanine into tyrosine. You can also see increased levels of phenylalanine metabolites, and you have normal concentrations of tetrahydrobiopterin, which is the cofactor for the enzyme. So the tandem mass spec, again, quantifies the Phe level and all the other amino acids, so you've already bypassed where I would see patients in clinic 20 years ago. You're already starting with the amino acid profile. So about 2% of babies that have a high Phe level on their newborn screen actually have a defect in recycling tetrahydrobiopterin. These kids will continue to have neurologic signs despite great dietary therapy, and you have to treat them with extra tetrahydrobiopterin, L-DOPA, and 5-HT. So again, you need the tetrahydrobiopterin to make the phenylalanine hydroxylase work. Treatment is low Phe intake for life. That's about 40 milligrams per kilogram per day. And we do that with phenyl-free formulas. So you count how much Phe you eat, and then you supplement back in all the rest of the amino acids in the formula. Because if you're doing a low-protein diet, you're not getting all of the amino acids in. So you just do this protein shake minus the Phe. We monitor their blood levels and adjust the Phe intake. For women, we need preconception dietary control to prevent teratogenic effects of elevated Phe. So this is maternal PKU. 80% of exposed fetuses will have microcephaly, intellectual disability, growth impairment, and congenital heart defects. So the placenta actually concentrates the Phe level about 1.5 times. So if mom's at 20, the baby's seeing 40 to 60. So there's also a high rate of loss if you have completely uncontrolled PKU while you're pregnant. All right, tyrosinemia type 1, autosomal recessive, presents with failure to thrive, a big liver, renal failure, and rickets, and liver cancer. The symptoms are due to not because of the high tyrosine, but downstream, it's making a compound called succinyl acetone, and that is poisonous to your liver and to your kidneys. Some of the state screens are now testing for SUAC or succinyl acetone. Tyrosine is a little harder to pick up on tandem mass spec, and you may only have subtle elevations, and so the pathognomonic compound here is the succinyl acetone. So our treatment is to block the step before you make the succinyl acetone, hence taking away the toxin. And again, the newborn screen may catch it, but it's a little tenuous, so we've started adding this compound. It has a fancy name now, the medication. I learned it as NTBC, but it's nitisinone. And we put them on a low tyrosine diet, and we have a much better survival rate. All right, so here is the pathway. Here's the happy phenylalanine, where we can only enter here. We turn it into tyrosine. But with type 1 tyrosinemia, we are actually blocked further down the pathway, which explains why we may only get modest elevations of tyrosine. When we block here, we shuttle off to succinyl acetone as our side pathway, and this is the problem. So we give NTBC, which knocks out this enzyme. So we turn one enzyme deficiency into another. Now you can't make the succinyl acetone, and it goes away. Now you have to go on dietary therapy to help balance out your tyrosine and your Phe, but you've taken away the evil toxin over here. All right, so another case presentation. 24-month-old male. He's noted to have a wide base gait at 18 months. He has a history of gross motor delays, but his fine motor is intact. The neurologist got an MRI. He shows diffuse white matter abnormality consistent with a dysmyelinating disorder. And he was referred to neurology for a possible metabolic brain disease causing his ataxia. His labs come back with minor elevations of AST and ALT. His CK is mildly elevated at 410. He has a normal lactate and pyruvate. Plasma amino acids have a very high methionine at 859 with a normal high of 53. So all of the labs that I look at, I'm looking for something that is substantially different. Not just 54, okay? Because that's the most common questions we get asked. We all have these minor variations in all the labs we get. We're really looking for something many steps off. The total plasma homocysteine is also very high at almost 170, with normal being less than 10. So this is homocystinuria. And it's most commonly due to cystathione beta synthase deficiency. It gives you elevated homocysteine. Clinical features are the marfanoid body habitus, developmental delay. They have ectopia lentis, but it tends to be a downward ectopia lentis, where Marfan's tends to go upwards. And they have an increased risk of thromboembolism. The treatment is pyridoxine for those that are vitamin responsive. We give them a diet low in methionine. We supplement them with L-cysteine betaine, and that increases the homocysteine to methionine, because we can tolerate the high methionine, but it's the homocysteine that gives us the risk factors. Maple syrup urine disease, or MSUD, is about 1 in 150,000 live births, unless you're in the old order Mennonites, and then it's about 1 in 176. And Indiana has a high population of old order Mennonite, and they were one of the first states to have MSUD on their newborn screen. Now we all screen for it. It's a defect in breakdown of branched chain amino acids. For those that don't remember, valine, isoleucine, and leucine are your branch chain. And so you'll see that in both your plasma and your urine. If you ever see an allo-isoleucine, that is pathognomonic for MSUD. When we're treating kids with MSUD, we want to monitor their leucine, because that's the one that gives you the most problems with encephalopathy. So we try to keep the valine and isoleucine within range as well, but primarily we focus on the leucine. So they present with CNS disease. They have this unusual odor of maple syrup. And I can't tell you how many kids I've worked up over the years, because everybody thinks their kid smells sweet in their urine. Doesn't hurt just to get the plasma amino acids. If your 3 branch chains are normal, it's not MSUD. And in this day and age, it's unlikely it would have been missed. I do have parents who have wandered off, not to ever be found with their child. So there are still children in the United States who have not gotten their newborn screens because parents have wandered away. So it never hurts to get the amino acids. Onset is usually within 3 to 5 days, with feeding problems, hypoglycemia, seizures, lethargy, coma, and death without treatment. All right, non-ketotic hyperglycinemia. This is also known as glycine encephalopathy. It's autosomal recessive. The glycine accumulates in all tissues, especially the brain. Presentation. On the history, looking for in utero hiccups. Classic presentation is a neonatal seizure and apnea that requires intubation. And this occurs before you've had substantial PO intake. So rather than the intoxication building up over the first several days of life, this kid in 12 hours is starting to have apneic episodes and seizures. Atypical, the seizures can be mild, or you can have a severe course. I've actually diagnosed somebody that was home for about 1 to 2 months before they started having their apneic episodes. On a testing situation, it's going to be that classic presentation. So progressive lethargy, hypotonia, myoclonic jerks, and seizures, and if unrecognized, leads to apnea and death. In those children who do survive, there's profound intellectual disability. The atypical forms have variable outcomes, but they all have some form of neurologic impairment. And the way you make the diagnosis is getting paired CSF and plasma amino acids and looking for enrichment of the glycine in the CSF space. All right, term newborn experiences tonic-clonic seizures and becomes apneic 12 hours after birth, requiring intubation. Prenatal history was unremarkable except for the baby having hiccups throughout the last trimester. Born via vaginal delivery, APGARs were 9 and 9. Family history is negative for seizure disorder. Physical exam is unremarkable apart from the seizures and hypotonia. Trial of phenobarb and phosphinetoin, the seizures stop. However, he's not having any respiratory effort and remains intubated. Which of the following is the most likely etiology? and this is non-ketotic hyperglycemia. You started within 12 hours, you're seizing, you've not really had any time to eat a lot. PKU is asymptomatic. Seizures occur long-term. MSUD, usually asymptomatic in the first couple of days. Homocysteine, you pick up later. Pyridoxine dependency would be refractory to the phenobarb and phosphoenolactone. All right, urea cycles. 6 diseases, 1 is X-linked. So that's the OTC. So 6. Overall incidence altogether is about 1 in 8,500. All of them, well, most of them, hyperammonemia. Look for increased glutamine on your serum amino acids. There's not going to be a ketoacidosis, but you're going to have a respiratory alkalosis and mild or no liver dysfunction. Look at your citrulline on your serum amino acids and look for a urinary orotic acid. Those are going to be your helpful keys for the A to B to C. All right, so here's the cycle. Goes round and round. And we're going to go through each one of these steps. The reason why we start having findings in this whole group is astrocyte swelling due to ammonia and increased glutamine. They will present with vomiting and poor feeding, and the brain edema causes lethargy and confusion. Usually the ammonia has to get above 100. Remember that babies already have higher ammonia levels, so if you have a baby with an ammonia of 60 to 70, that can be perfectly normal. You really don't start seeing encephalopathic changes until you're over 100. As you go higher, then you can have coma and you can herniate your brain. So case presentation of a 48-hour male, normal term pregnancy, no problems, parents' 3rd child, discharged home at 12 hours of life, and parents are concerned because he ate well for the first day, but today they cannot wake him to eat. He's breathing fast, he's lethargic, he's hypothermic. We get some lambs. We see the bicarb is at 40, pH is 7.45, and the ammonia is 800. So this is the classic presentation for OTC deficiency. Remember, sepsis is always much more likely than an inborn error, especially if you're doing something within the first 24 to 48 hours of life. The baby's crashing, you're still going to work them up for your sepsis. Call the newborn screening lab and ask for that lab to come back. So classic, normal at birth, male infant. Remember, that's the one that's X-linked for OTC, and the respiratory alkalosis and lethargy after 48 hours of a protein intake. The rapid breathing could also be consistent with a ketoacidosis and congenital diabetes. In lethargy in a neonate, always think about your hypoglycemia. All right, so onwards through the urea cycle. CPS1 and NAGS deficiency. Both are recessive, and you're unable to start the urea cycle. They will present with vomiting, lethargy, and coma. They will have very high ammonia, low or normal orotic acid, low citrulline, low arginine, and these 2 conditions are indistinguishable without molecular testing because you need both to start the cycle. So one or the other is just going to result in the same phenotypic presentation. So on a test, they shouldn't give those 2 to you to distinguish without a molecular test. All right, so up at the top, if CPS goes away, then ammonia goes up, you can't make orotic acid, citrulline goes down, and arginine goes down because you can't get into the cycle. So that's CPS1. If you take out NAGS, ammonia goes up, can't make orotic acid, citrulline goes down, arginine goes down. So they look exactly the same on screening tests. All right, OTC. X-linked, you can't break down protein, you get vomiting, lethargy, coma. The female carriers can be symptomatic with illnesses and protein load. So remember that X inactivation, you might look just fine up until your husband makes you eat beef because you live in Iowa and you shouldn't be a vegetarian. That's one of the stories from one of our patients. Her mom died within about 48 hours after giving birth to her. She was raised by her parents, by her grandparents. She avoided protein because it made her feel icky, and her grandparents felt very bad for this little girl who had lost her mom and never made her eat meat. So she got married. Her husband made her eat meat, and the way they tell the story is, and we got married and my husband tried to kill me. She presented with her first hyperammonemic attack after being married and eating a full protein load. So women can look just like the boys if in the right scenario. And it's not uncommon to see that on the adult ICUs that this has been missed. So be aware that it's out there. Very high ammonia. This one will give you an elevated orotic acid, a low citrulline, and a low arginine. So here's OTC at the top. You take it out. You're backed up behind now, so the orotic acid goes up along with your ammonia. After the block, the citrulline is still down and the arginine is still down. So that's OTC deficiency. Citrullinemia has an unfortunate abbreviation. It's arginosuccinic synthase, giving you ASS deficiency. Okay. Autosomal recessive, vomiting, lethargy, coma, high ammonia, normal orotic acid because you're moving a little bit further into the cycle, high citrulline, low arginine. This is not type 2 citrullinemia. It's a different enzyme and a different presentation. All right, so here's citrulline. We take away that enzyme. Citrulline goes up, and ammonia goes up, and arginine goes down. So up to this point, both the citrulline and arginine have been down. Now the citrulline has gone up. Arginosuccinic aciduria, autosomal recessive, vomiting, lethargy, coma. This one has a hair phenotype, trichoriasis nodosa, so this broken hair. And so if you're thinking this is what it is, you can have your friendly dermatologist come by, pluck hair, and look at it underneath the microscope and make a diagnosis. High ammonia, high citrulline, high arginosuccinic acid, and low arginine. So when this enzyme goes away, back behind, the citrulline goes up. My arginosuccinic went away, but there's citrulline, ammonia, and the arginine is still down. So again, you're just looking for these patterns of A to B to C. Argininemia is also known as arginase deficiency. It's autosomal recessive. And this one's a little bit different. Now we're going to get problems from arginine in the brain. And this one presents as a progressive cerebral palsy. So anytime you have a progressive static encephalopathy, there's a problem, and you should reassess that. They can have tremor, ataxia, and chorioathetosis. They have a normal ammonia, but a high arginine. So when arginase goes away, arginine goes up. And that's argininemia. All right, so here's the cheat list, because at 2 o'clock in the morning when you get asked this question, you're not going to want to run through the cycle. All right? NAGs and CPS, you can't tell them apart on biochemical labs, but they'll have low orotic, very high ammonia, low citrulline, low arginine. OTC, high orotic acid, high ammonia, low citrulline, low arginine. So here's the difference between these two. Citrullinemia, ASA, and argininemia all have normal orotic acid, but tell the difference between their ammonias and their citrulline to arginine. OTC is X-linked, ASA has trichoriasis nodosa, and argininemia is the outlier that gives you spastic diplegia. Other urea cycle-related disorders, citrin deficiency is citrullinemia type 2. That can give you a neonatal hepatitis. Triple H syndrome gives you hyperornithine, hyperammonia, and hypercitrulline. And this also gives you a progressive spastic di and quadriplegia. And then lysinuric protein intolerance is due to a problem in your dibasic amino acid transporter. So you get an elevation of lysine. What's a problem of lysine, arginine, and ornithine? So if you have a problem with ornithine getting into your urea cycle, it begins to slow down as well. But these people also have interstitial pneumonia, glomerulonephritis, osteoporosis. All right, Treatments. Use alternative pathways to get rid of your nitrogen, like sodium phenylbutyrate or acetate, and then arginine or citrulline to help drive the cycle around, unless, of course, you have arginemia. Then you don't give excess arginine to somebody who already has too much. Increase your caloric intake. You want to do protein restriction, but not below the RDA. Because these kids, even though you want to restrict how much protein they're getting, if you don't get enough, you'll break down your muscle and throw more protein in. So you want to just keep it well controlled at the RDA. If you're having high ammonia, you can use hemodialysis to get rid of the extra ammonia. And so really what you want to do in those acute instances is shut down the catabolism, giving lots of sugar, get rid of the small molecule, which is the ammonia, and make sure you don't over-restrict your protein because you can actually continue to produce more ammonia if you're not giving them enough protein. All right, onward to the organic acidemias, also known as acidurias. So propionic, methylmalonic, isovaleric, and glutaric. Case presentation, previously healthy 16-month-old male, woke up this morning with acute onset of weakness and lethargy. He woke up at 5:30, he was alert, took a sippy cup and went back to sleep. Woke up at 7:30 with decreased responsiveness and dilated pupils. The ambulance was called, taken to the emergency department, and upon arrival he was gasping with decreased level of consciousness and intubated for airway management. Vital signs, he was responsive only to pain. He was limp with minimal movement, and his admit labs. So his glucose is 47, CO2 of 5.7, ammonia 57, and his pH is 7.03, and his base XX is 24.3. Initially did well with IV hydration and glucose. Sugar makes most things better. He became hyperglycemic, so they decreased the glucose, and then he became acidotic again. So they restarted the glucose with good resolution of acidosis. One of the most common questions I get asked is, should we treat the hyperglycemia? We're afraid we're going to make the child diabetic. Just give more sugar. Sugar is always good, okay? Because what you're trying to do is shut down the catabolism while you're figuring things out. Because there's an abnormal acid coming from somewhere. So let's just shut that down, give them lots of sugar. So this little one has methylmalonic acidemia. The urine organic acids showed massive elevations of lactic acid and methylmalonic acid. The problem here is that this lab comes back in about 2 weeks, okay? So while you're there trying to figure everything out, you've sent all these labs, keep giving them sugar and trying to stabilize their metabolic situation. The plasma amino acid showed elevations of glycine, and the acylcarnitine profile showed elevated excretion of propionyl carnitine and methylmalonyl carnitine. So your plasma amino showed it, your urine organic showed it, and your acylcarnitine showed it. Remember, we talked about non-ketotic hyperglycinemia. This is ketotic hyperglycinemia. Here's the elevation of glycine, but you're throwing off a bunch of lactic acid and methylmalonic acid. So common to all of the organic acidurias is a high anion gap metabolic acidosis. And it's disordered catabolism of selected amino acids, fatty acids, and carbohydrates. And the symptoms are a result of the buildup of the keto acids. They generally present in the neonatal period with intermittent illnesses, with ketoacidosis. The hyperammonemia is mild to moderate, and it's because you're acidotic. All your enzymes are unhappy when you're acidotic, including your urea cycle enzymes. So you may be given an ammonia that is mildly elevated, but it doesn't look like OTC deficiency. So once you correct the acidosis, the ammonia should correct as well. Hypoglycemia and bone marrow suppression can also be seen. So what we want to be able to make the diagnosis is all those beautiful labs that'll come back not in the acute setting, so a characteristic organic acid profile and specific enzyme diagnosis from white blood cells or fibroblasts. These people go on a low-protein diet, specific formula without the offending amino acids, supplemental biotin and carnitine. So propionic is autosomal recessive. It gives you a ketotic hyperglycemia, as does methylmalonic, mild to moderate hyperammonemia, high anion gap metabolic acidosis. And that gap, that is an unmeasured acid. So it's out of keeping with the amount of ketones or lactic acid you can see on the labs you can get in the hospital. Propionic can also give you cardiomyopathy, a dermatitis, pancytopenia, and pancreatitis. Urine organic acids will give you the specific metabolites like propionyl carnitine and 3-methyl citric acid, and elevated glycine on your amino acids, and the glutamine may be elevated as well. We want to restrict the branched-chain amino acids and protein intake, correct the metabolic acidosis, and during crisis, give lots and lots and lots and lots of sugar, and don't stop. All right, clinical pearls for the organic acidemias. The propionic and methylmalonic will give you the ketoacidosis, osteoporosis. All of these can be precipitated by infection, which then cause you to go down this disordered metabolite route. They can be misdiagnosed as pyloric stenosis. Isofilaric is the sweaty sock disorder. So if you have the smell of sweaty feet or sweaty socks, think about isofilaric. They have an encephalopathy. The chronic form can give you pancytopenia and then again recurring acidosis. GA1, these kids are macrocephalic at birth. They have cortical atrophy and rarely present with a metabolic acidosis. This is more common in our Amish populations, and it's one of the few causes of retinal hemorrhages and subdural hematomas that are not from shaken baby. So again, in the NAT workup, getting a metabolic evaluation is important to make sure you haven't missed something that's actually treatable. All right. You're urgently called to the newborn nursery to evaluate a 3-day-old term male infant who is lethargic. The baby was taking formula well for the first 2 days, but vomited after his last 2 feedings and has become increasingly difficult to arouse. Pregnancy, labor, and delivery were uneventful. APGARs were 8 and 9. Family history is non-contributory. Baby is limp, lethargic, and unresponsive. You order lab tests, you start your IV fluids, and arrange for transfer to a NICU. Critical lab values: platelet count of 35, serum carbon dioxide of 45, serum ammonia of 600, total bili at 20, no ketones in the urine. Which of the following is the most likely diagnosis? And we've got the right split. So this is citrullinemia, but propionic is the next best guess because you have that elevated ammonia. So high ammonia after several protein feeds. Propionic is possible, but you'd expect a high anion gap metabolic acidosis. Transient hyperammonemia is almost always in preterm infants with pulmonary disease. You still treat it aggressively. Bilirubin, that's nice, but it wouldn't give you that type of high ammonia, and the normal delivery and intake makes the HIE really unlikely. All right. Lastly, to the sugar intolerances for our intoxications. So examples are galactosemia and hereditary fructose intolerance. So an 8-day-old male is being seen in the pediatric clinic for his 1-week checkup. You look at him, you think he looks jaundiced. Total bili was at 32. And he's admitted to the NICU for possible exchange transfusion. The total bili was 32 on admission with a direct of 0.9, and it came down with phototherapy, thereby avoiding the exchange transfusion. His initial coags, PTT was elevated. He was given fresh frozen plasma, and it came down. And the newborn screen came back positive for galactosemia. We switched the baby to soy formula, and he's done well since then. So galactosemia has an incidence of about 1 in 50 to 100,000, and it's a deficiency in galactose-1-phosphate uridyl transferase, abbreviated as GALT. Clinical features: vomiting and diarrhea in the first weeks of life, liver disease with jaundice, cataracts, and the infamous E. coli sepsis. If you see E. coli sepsis in the clinic or on a test, think about galactosemia. So we pick it up on newborn screening with a low enzyme activity and a high Gal-1P. And you can get positive urine-reducing substances, which is the galactose in the urine. We put them on a galactose and lactose-free formula, which is soy formula. So remember, lactose is a disaccharide made of glucose and galactose, which is why we take lactose out. So breast is best, except if you have galactosemia and you need to be on a soy formula. Less common forms of galactosemia is galactokinase deficiency, epimerase deficiency. Overall, they don't present as neonates. All galactose metabolism can cause cataracts, and these are not detected on newborn screen because we test specifically for GALT enzyme activity. Hereditary fructose intolerance is about 1 in 23,000 in the European population, less common in others. It's a deficiency of fructose 1,6-biphosphate aldolase, and you accumulate fructose 1-phosphate, which gives you the toxic symptoms. You are healthy unless you ingest fructose or sucrose. So remember, sucrose is a disaccharide made of glucose and fructose. The problem in the United States is we all like things that are sweet. So we have high fructose corn syrup in a lot of our prepackaged foods. So not just eating fruits where you get the fructose directly, but your table sugar and then the additives to the foods. Usually presents about 6 months of age when you introduce fruit and fruit juices. Gives you jaundice, hepatomegaly, vomiting, lethargy, and seizures. You can get severe hypoglycemia. You'll see urine-reducing substances. Abnormal liver function test, hyperbiliary, and prolonged clotting times, low albumin, and a proximal renal tubular dysfunction. So we treat them a diet without sucrose, fructose, or sorbitol, and you get resolution of your liver and kidney damage. And intellectual disability is uncommon. It just can be really difficult to avoid all of those things in the United States. All right, so you're reviewing the formulas your hospital keeps in stock in case you get a sick infant on the weekend because apparently you have no outside life, okay? Which disorder is best treated with the commercial soy formula? Excellent. So galactosemia. Do not pass go. Do not collect your $200. For a while, there have been lacto-free formulas that are out there. There's still lactose in those. The true lacto-free formula is soy, so they have to be on the soy formula. Urea cycle defects have their own supplements, as do PKU and tyrosinemia. And hereditary fructose intolerance doesn't have a formula, but just dietary restriction. All right, now we're going on to energy metabolism. All right, so this time when we see A to B to C, and A to B is knocked out, A would go up and B and C would go down, but our problem is going to be by having not enough of C, as opposed to having too much of A. Problems with glucose, glycogen, proteins and fats in our mitochondria. So our long-term fasts give us problems with proteins and fats. Glycogen has problems with short-term fats. Mitochondria, I love my mitochondria. I hate mitochondrial diseases. They present like everything. All right, fatty acid oxidation defects occur with problems in breaking down your fatty acids. These are included in your newborn screening. Glycogen storage diseases occur with defects in breaking down glycogen. Mitochondrial disorders or respiratory chain disorders, defects in the electron transport chain. You can't pick these up on newborn screening. The molecules are too small and the way that we pick them up is different. So you're unable to utilize your normal resources of stored energy. The problem can be anywhere in your ATP cycle, from fatty acids to glucose to protein. Fasting or illness with increased energy needs can exacerbate the disorder and bring on decompensation. Hypoglycemia is usually the last sign. You'll often be lethargic prior to complete collapse. Everybody in here knows you never trust a baby anyway. They may be looking just fine, and then they're not. They can present with failure to thrive, hypoglycemia, lactic acidosis, hypotonia, myopathy, cardiomyopathy. We think about 3 to 6% of historic SIDS were due to disorders of fatty acid oxidation disorder. Look at the pregnancy history. If mom had HELLP syndrome or acute fatty liver disease, that may be a sign that there's a problem in the baby and mom is a carrier, and that was enough to trip her over the edge to be symptomatic. The diagnosis can be difficult. Findings on screening tests are usually nonspecific, and the exception is the fatty acid oxidation disorders, where we can pick them up on newborn screening with the acyl-carnitine profile. You'll likely require skin, muscle, or liver biopsy to confirm your diagnosis, and mitochondria are different in different populations in different tissues, so you may need to test multiple tissues. So if you did a skin biopsy, that might not be normal. You may need your muscle and liver. All right, so let's start with the fatty acid oxidation. So this is the beta oxidation of fatty acids in the mitochondria, and it provides energy for the skeletal and heart muscle during fasting from fat breakdown. So even though I'm up here drinking my caffeine with lots of milk and sugar in it, I'm relying on my fatty acids to keep me going. So that's your normal metabolism. If you can't do that, then you're going to continue to slow down and be hypoglycemic. We generate an acyl-CoA used for ketone body production rather than glucose, and we do that 2 units at a time. So we have progressive fatty acid chain shortening and carnitine transport. So you take a C14 compound and cleave off 2 to go down to C12 and throw off an acetyl-CoA. Do it again, you get C10 and throw off an acetyl-CoA. And you keep doing this sequentially down. So you can have a long chain problem, a medium chain problem, or a short chain problem. You will get a hypoketotic hypoglycemia. So you now have run out of your sugar source, you've used your glycogen, and now you want to go rely on your fats. And if you can't break down your fat to throw off those acetyl-CoAs to make your ketone bodies, you become hypoglycemic and you're not making enough ketones. You'll also watch your uric acid go up because you'll start relying on some of your muscle breakdown. You'll see a dicarboxylic aciduria, acidosis, and you can still get a hyperammonemia due to the acidosis, but it's mild again when you compare it to urea cycle defects. The most common of all of them is the medium chain acyl-CoA dehydrogenase deficiency, or MCAD. Usually presents in the first 2 years of life. Fasting-induced vomiting, lethargy, seizures, coma, and is a rare cause of SIDS. Prior to newborn screening, about 25% of children died with their first illness. When you make the diagnosis on your newborn screen or on an acyl-carnitine profile, you see an elevation in C8, C8-1, and C10-1 esters. We treat them with frequent feeding. Don't let them get to a long-term fast. So if you can block at C8 to C6, C8 goes up, and you also see the esters being made because you're getting the block back behind there. You also see a bump in your C10. And this is what the newborn screen is looking at. So how this would present: an 18-month-old boy who's not been eating well for the past 2 days, has had a fever since this morning. His mother is worried because he just isn't acting like himself. He's not playing and he's sleeping all the time. He had an older sister who was found dead in her crib after a similar episode at 12 months of age. You see him in clinic. You get white cells and lots of lymphocytes. Your glucose is 40. Your ammonia is 180. On exam, he has hepatomegaly, and he was born out of state and did not have expanded newborn screening. That's becoming less and less frequent over time. You get the following test while you're starting your IV: a free and total carnitine and an acyl-carnitine profile. About 2 weeks later, your acyl-carnitine profile comes back with an elevated C8, C8-1, and C10-1. So this is MCAD. That was the pathognomonic pattern for that. These kids will develop hypoglycemia when they're forced to rely on fat for energy, fasting, stress, or illness. And this history of a sister who died of a similar issue. It's an autosomal recessive condition, so it's a 25% recurrence risk, and 3% of SIDS are due to fatty acid oxidation defects. And MCAD is the most common of that group. So you always check a glucose, but if it's normal, don't assume that you're not in trouble. So other fatty acid oxidation disorders. Short chain is unlikely to cause symptoms, and it has been removed from some newborn screens because we think it's a non-entity. You're getting all the energy you need, and if you can't do the last couple of steps, it doesn't cause you health problems. Long chain, the liver and heart are most affected. You get an earlier onset of symptoms and retinal changes. And VLCAD, very long chain, heart and skeletal muscle are also affected, and again, earlier onset symptoms. If you can't make it very far into the system to extract energy from it, you're going to get earlier onset of symptoms. You can also have acylcarnitine transporter defects, so you can't get the fatty acids into the mitochondria to burn them for energy. And so these look like the long chain disorders because you can't burn the energy you have. All right. 6-month-old is admitted to the hospital for evaluation of failure to thrive after waking up this morning having a seizure. Upon arrival, she was still seizing and her glucose was 10. On physical exam, she appears wasted and has a protuberant abdomen and marked hepatomegaly. Lab evaluation reveals fasting hypoglycemia, lactic acidosis, hyperuricemia, and hyperlipidemia. Which of the following describes the best long-term management of this disorder? I'll give you a moment to read them. And go. Excellent. So this is one we haven't talked about yet. So this is intro to the next one. So this is a very typical GSD or glycogen storage disease. So we can't break down our glycogen to get it out of the liver to maintain our glucose. And we want to help with that by giving the child cornstarch, so a necessary starch to be able to get their energy from. Fatty acids and protein supplementation will not address the issue. Glucagon, we want it to release the sugar from the liver, but if you can't, the glucagon won't work. And IV dextrose is nice, but you can't go home with it. So you got to give them something else. All right, so that's a glycogen storage disease. So this is a defect in making or breaking down glycogen and its sugar components. GSD 0, actually you can't even make the glycogen, so you won't get a big liver. But you can't even store anything to go get from the store to make your glucose. GSD 1A and 1B, the defect is in breaking down glycogen due to glucose 6-phosphatase deficiency, and GSD 3 is a debranching enzyme. So here's your glycogen for the debranching. You get down to a certain amount, and you have to take this stub and put it on the end of another one so you can eat away at the glucose that way. So it's a little less severe than the GSD 1, but you still can end up with hepatomegaly and hypoglycemia. So you can store your glucose, but you can't get it back out of the liver. And so if you have a short-term fast, then you're out of luck. You also have problems in your liver because you're having all this glycogen stored that you can't get back out again, so it disrupts the way that the liver can work. So here's the case presentation. Generally well, 19-month-old, small size, developmental delay, admitted for feeding intolerance and vomiting. The physical exam was notable for hepatomegaly. She dropped her blood glucose to 44 during the hospitalization. She had increased transaminases, and bilirubin was 0.8. And she's to follow up with pediatric GI. The labs 3 days prior to the clinic visit shows that her transaminases continue to rise. So this little one has GSD type 1A. Her nutritional and liver labs showed it, total protein was good, albumin was good, but her uric acid is elevated. and as is her cholesterol panel. So she has an elevated cholesterol and triglycerides. We do a mutation panel, which can take a month or so to come back as well, but it's consistent with GSD type 1A. And again, this is a defect in glucose 6-phosphatase in the liver, kidney, and intestinal mucosa. You can't get glycogen back out for your short-term fast. The 1B is actually a translocase defect. You get a fasting hypoglycemia presenting at about 3 to 4 months of age, right when you stop feeding the kids every 2 to 4 hours. You're expecting them to start to sleep through the night, go a little bit longer between those feeds. They can present with hepatomegaly and seizures, doll-like facial features, protuberant abdomen, and long-term they have liver disease, gout, delayed puberty, pancreatitis, hepatic adenomas, renal stones, and hypertension. Key lab findings: hypoglycemia, because you can't make glucose from your stored glycogen. Lactic acidosis, because you're going to rely on your anaerobic metabolism to get energy. Hyperuricemia, because you're breaking down protein to make new glucose. Hyperlipidemia, because you're breaking down fat to make more energy. Elevated liver enzymes from storing the glycogen in the cells. Type 1B can give you neutropenia. And you make tons of ketones because you're using your fat and your protein for energy. We now do a gene-based mutational analysis for definitive diagnosis. We used to have to do a liver biopsy, but we don't have to do that anymore. We will give them continuous NG feeds once they're able to eat and tolerate it, giving them uncooked cornstarch, and eliminate fructose and galactose from the diet. We also give them allopurinol to help with the uric acid. So other key features: if you've got type 0, you will not have the hepatomegaly because you have no glycogen stores. Type 3, the debrancher enzyme, you're unable to use the glycogen when it reaches that branch point. So again, looks like GSD type 1. Another type of GSD is McArdle's disease, which is GSD type 4, but it is a muscle problem, not a liver problem. It's autosomal recessive, usually presents in young adults or teens, and you get muscle cramps associated with rapid exercise. They will have an elevated CK even when at rest, and they have a second wind phenomenon. So they will weaken out when they're trying to exercise, but then recoup and be able to go again. They can get myoglobinuria, which may lead to acute renal failure, and then progressive muscle weakness and atrophy with fatty replacement. All right, so you're going to see a 2-year-old female for her first physical after being adopted. Paperwork states that the parents were first cousins. She has mild developmental delays and shyness attributed to her time in the orphanage. Her height's at the 25th percentile, weight is less than the 5th. She has a protuberant abdomen due to hepatomegaly. There is no splenomegaly. Skeletal survey shows metaphyseal flaring of the distal radius and nodularity at the costochondral junctions. If left untreated, this patient is most at risk of all right, so this is indeed the hepatoblastoma. This is tyrosinemia. Actually, I'm going to go back one. The E. coli sepsis is galactosemia. Subdural hematoma is GA1. Thromboembolism, homocystinuria, hypoglycemia, everything. And hepatoblastoma is tyrosinemia. So what gives you a big liver? She's made it to the age she is being adopted in an orphanage without hypoglycemia. So unlikely to be anything other than the tyrosinemia, but she also has these bone findings of rickets. And remember, the succinyl acetone poisons the kidneys as well. And then it gives you this secondary finding of rickets. All right, on to mitochondrial diseases. So there's a defect in the respiratory chain pathway. It's an end common pathway where you're unable to convert your glucose, fat, or protein to ATP. Variable presentation with variable age of onset. This is my least favorite group of disorders. What are the mitochondria and why do they cause us medical problems. I think of them as the powerhouse of the cells. They are the power plants. That's where we go to burn all of our energy. When the cells need more energy, the cells make more mitochondria. There are organelles that have their own DNA. So we have ours, which is the nDNA or nuclear DNA, and this is the mitochondrial DNA. There are multiple mitochondria in every cell, and they are necessary for aerobic ATP production, and they divide independently of the cell cycle. So they're doing their own thing in each side of each cell. You can get a disorder of your mitochondria in 5 ways. You can have a true mitochondrial disorder due to a mutation in the mitochondrial DNA with maternal inheritance. You can have nuclear encoded problems that are recessive, dominant, or X-linked. And the vast majority of the machinery that is in the mitochondria is imported from us. So we make it, and then we import it into the mitochondria. There are very few of the genes that are encoded on that mitochondrial DNA. And then you can have acquired problems. So different medications or radiation, you can damage the mitochondria and induce mitochondrial disease. There are more than 40 different mitochondrial diseases. There's a problem of heteroplasmy. This mitochondrial population is different from cell to cell. And so your mitochondria may have different mutations in different cell types. So when we try to do mitochondrial testing on a blood sample, we may or may not find the actual mutation in the mitochondrial DNA if it's not at a high enough proportion for us to see. Mitochondrial diseases can give rise to any symptom in any organ or tissue at any age. This is very unhelpful. So one of the sayings we have, you can only rule in a mitochondrial disease. You can never completely rule it out. If we think about it in a much more global way, aging is a disorder of mitochondria. The more dysfunctional your mitochondria become over time, the less efficient, the less muscle strength you have. All of those things can come along with the aging mitochondria. So the things that we really want to look for are things that are related to energy deficiency. Cardiomyopathy, neuromuscular symptoms, seizures, poor growth and failure to thrive. So things that look for high energy systems. And along with these also are things like hearing loss and vision loss. What are your high energy systems? So some of the more common classic mitochondrial diseases are Ehlers-Danlos hereditary optic neuropathy, MELAS, mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, Kearns-Sayre and Leigh syndrome, and MRF, which is myoclonic epilepsy, and ragged red fibers. So here we get we get all of our mitochondria from our mom. The sperm use the mitochondria to swim. So in this ovum, we have 3 mitochondria. They start to make more mitochondria inside those cells, and they're all happy. If the ovum started with just one of its mitochondria being abnormal, this cell then is going to give rise to a whole population of cells that have mitochondria in them that carry that mutation. So here's that lonely cell. It starts replicating, and the mitochondria in here are all abnormal. You can also take a hit later in life, right? So as we age and the mitochondria are just having electrons thrown around and the DNA is not sequestered away, so it's in a high oxidative environment, and so it can get free radical damage, and so you may have secondary rather than inherited mitochondrial disease. So to make the diagnosis, one, you have to have a higher level of suspicion. Are you looking at high energy groups? And then we want to look at the blood. We want to look at lactate and pyruvate. So send those 2 things together because it's going to tell you about the redox potential of the person. If you're not able to use your oxygen through as the final electron acceptor in your mitochondria, you're going to keep backtracking up to pyruvate and over to lactate and use your anaerobic metabolism. So you may have sort of a baseline elevation in that lactate, but it's easy to be elevated with blood draws. So making sure that the kid isn't screaming and doing silly things, which never happens. I write all sorts of things on notes, right? Please draw while child is calm on free-flowing blood. Right. Look at your plasma amino acids. Your proline and alanine may indicate a mitochondrial dysfunction if they're elevated. And mutation analysis, again, is tricky because of this idea of heteroplasmy, and then the difference between true mitochondrial mutations versus nuclear DNA mutations. The better our technologies have gotten, we now have panels where we can look at a bunch of the nuclear genes in addition to the mitochondrial genes that go to the electron transport chain. It's always better to have an idea what you're looking for when you're looking. So if you sort of have an idea from your labs where the problem is, that's always helpful. For therapy, a lot of people will put people on a mitochondrial cocktail, except there's no case-controlled studies or controlled trials for those. Outcomes are subjective. We have no evidence that it harms people, but we have no evidence that it actually helps. So some people will put them on antioxidants and reduce the damage by the free radicals. So coenzyme Q, lipoic acid, vitamin C, and vitamin E. And to help support complex 1, some people will do carnitine, thiamine, pantothenic acid, and riboflavin. Again, we have no evidence that it harms. We have no evidence that it helps. So this is based on theoretical, what we know about biochemistry. All right, 4-month-old male is brought to the emergency department after being found limp and apneic in his bed this morning. He is unable to be aroused. Mom reports that he'd been healthy and developing normally. When he developed yesterday, a little bit of diarrhea and vomited once. She reports that he fed normally at 8 p.m. and went to bed. He's been sleeping through the night for the past 2 weeks. On physical exam, his growth is normal. He is pink and stable. D10 IV fluids at maintenance after initial resuscitation in the ambulance. Initial labs, glucose was 15, pH is 7.2, PCO2 of 50, bicarb is 24. Urinalysis has no ketones, and he's otherwise normal. Which of the following is the most likely disorder in this child? And this is a fatty acid oxidation defect. He's been developing fine. He's now sleeping through the night. He's hypoglycemic, and he's not making ketones. So he's not breaking down his fats. He's not getting off the acyl-CoA to make a ketone. If you had a glycogen storage defect, you'd have hypoglycemia and a lot of ketones. And then the protein metabolism present with ketotic metabolic acidosis. And then at the end, we're going to talk about lysosomal storage diseases, but they don't present with these acute metabolic decompensations. All right. You will be asked at multiple points in your career and on exams about hypoglycemia. So this is my table. Everything in genetics is a 2x2 table. All right. So you will be given in every hypoglycemia scenario information about hepatomegaly, reducing substances, urinary ketones, and your response to glucagon. Your reducing substances, this HFI should be up here, no should be on the next line. So if you're making reducing substances, think about galactosemia and hereditary fructose intolerance, GSD and fatty acid oxidation disorders. You should not be throwing reducing substances. Big livers, GSD, galactosemia, HFI. No, with primary hyperinsulinism, pituitary dysfunction, and your organic acidemias. Ketones, yes, galactosemia, pituitary dysfunction, HFI, and GSDs. No to fatty acid. And remember, you might throw off a few. It can be hypoketotic, but really the difference is, are you throwing a whole bunch or not very much? And your response to glucagon. Oh, and that should be down there too. So hyperinsulinism should respond to glucagon. GSD, you won't. HFI, you won't. All right. And we're on to complex molecules. Two major categories, lysosomal storage diseases and peroxisomal storage diseases, and then a brief assortment of other categories. So with the complex molecules, your symptoms are permanent and progressive. They're not going to wax and wane like they do with all your intoxications and your energy problems. They often have multi-organ involvement, and the type of storage will go to the soft tissues primarily, your liver, your spleen, your heart, your joints, your airway. Some general screening tests that can be helpful. So you have to suspect the complex molecule and some very specific testing, as opposed to our standard when the child is trying to die in the emergency room. So urine oligosaccharides, urine mucopolysaccharides, lysosomal enzyme studies, very long-chain fatty acids, and serum sialotransferins, also known as carbohydrate-deficient transferins. Different hospitals will have different code names for those. The results are dependent on the lab running them. Make sure they are reputable labs. Just like you want your cardiac surgeon doing bypass to do many of those and not go, yeah, I think I can do it. I did it twice in fellowship. Probably not the person you want. If the lab is only running the test once or twice a year, you might want to go to the ones that are running it multiple times a day. Make sure that you've picked the right lab. For definitive diagnosis, many will need enzyme analysis or mutational studies. Until about 15 years ago, we had absolutely no treatment for this category of disorders, and our answer was just symptomatic management. Now we have a variety of enzyme replacement therapies, especially for the lysosomal storage disorders, which then leads us back to the conversation about newborn screening and how we keep adding more things in. It's not helpful to screen for something you don't have a treatment for, and now we're getting more and more treatments, so more things are being added to the newborn screens. Even with enzyme replacement, you need to manage the symptoms and be aware of common complications. And these are progressive disorders, so the new problems evolve over time. So we'll start with the lysosomal storage disorders. The lysosomes are organelles where we break down different large molecules. And so if you can't do that, the lysosomes become big and bulky. The primary molecules that are in there are your mucopolysaccharides, oligosaccharides, gangliosides or sphingolipidoses, and then the related lipid storage diseases. Most are autosomal recessive. Your two exceptions here are Hunter and Fabry. These kids are normal at birth. There can be a regression in development. All disorders are progressive and most are fatal. There is one of the glycogen storage diseases that is actually a lysosomal storage disease. So it is classified in both places, and this is Pompe disease or GSD type 2. And that's being added to different newborn screens as well. So rather than it being a mucopolysaccharide, this is glycogen that accumulates in the lysosome, and it's due to acid maltase deficiency. There are three forms. The infantile form, which gives you profound cardiomegaly and hypotonia and death usually under a year of age. From the EKG, you see high voltage QRS and shortened PR intervals. The juvenile form is slowly progressive with skeletal muscle involvement without the cardiac findings. And then the adult forms can come on anywhere between 20 and 70 with a slowly progressive myopathy, usually the lower extremities before the upper extremities and no cardiac findings. Mucopolysaccaridosis are the ones they love to test on. This is a defect in catabolism of glycosaminoglycans, and you get accumulation of dermatan, heparin, or keratin sulfate. And there's one of three forms for the presentation. There are ones with dysmorphic findings, ones with learning difficulties, behavior problems, and dementia, and then a severe bone dysplasia. So what you're looking for are these coarse facial features because the soft tissues are collecting the mucopolysaccharides. So you see here that the cheeks are full and the face looks very thickened. They can have distinctive bone changes, which are called dysostosis multiplex. They have joint stiffness and macrocephaly. They're prone to having hernias. They have a thickened mucosa, so a lot of people will come in thinking they have chronic seasonal allergies that never get better, repeated otitis media. Corneal clouding, deafness, and intellectual disability. What's the word I'm looking for? Not the pathognomonic, but the characteristic one that they love to test on is Hurler syndrome, or MPS 1. It's autosomal recessive. Typical clinical features: growth retardation, macrocephaly, coarse features, large tongue, corneal clouding, deafness, these frequent upper respiratory infections, obstructive sleep apnea, hernias, and mitral valve disease. We can do an enzyme replacement therapy. If you make the diagnosis early enough, you can do bone marrow transplant before the intellectual deterioration. If you do it afterwards, it does not reverse any of the intellectual problems, and it doesn't correct any of the skeletal abnormalities that are already present when you do the bone marrow transplant. MPS 2, which is Hunter syndrome, looks just like MPS 1, except it's X-linked. Severe looks like MPS 1. The milder forms can have a normal lifespan, and the difference is not only is the X-linked, but there's no corneal clouding. And one of the ways to remember that I've seen before is that Hunters need to have clear vision, and so they do not have the corneal clouding associated with it. We do have enzyme replacement. The other two MPSs, Sanfilippo's is MPS 3. It's recessive. You usually don't diagnose it till 4 or 5. They have very mild physical symptoms, so they may not have the hepatomegaly or such coarse features, but they will have regression. And they have a classic triphasic pattern with severe behavior problems. MPS 4 is Morquio's, autosomal recessive. This is a short trunk dwarfing condition. So they don't have the intellectual disability. They don't have the big liver, but rather than achondroplasia, which was a short limb, this is a short trunk. So they have an SED, which is unique for the MPSs. So SED is spondyloepiphyseal dysplasia. They also have an odontoid dysplasia. They can also get fine corneal deposits, and again, they have normal IQ. All right, parents who are new to your area bring their 4-year-old son to your office for evaluation of poor growth and developmental delays. They say that he was growing well until about 2, and now his height has dropped off. He's never had any words, but used to have about 20 signs. He's had multiple ear infections, and he's had PE tubes placed 3 times. His other developmental skills were on time, but in the past year or so, he stopped doing things he used to, like going up and down stairs. He's no longer signing, and he's become more aggressive with his family and peers. You review his records and note that his height was at the 50th percentile at 2, and it's at the 10th percentile today. On physical exam, he has dark and heavy eyebrows, full cheeks, full lips, but no hepatosplenomegaly or joint problems. Which of the following conditions is most consistent with this presentation? So this indeed is Sanfilippo. So it's unique in that you start having developmental regression. You may look a little coarse, but you don't have the big liver, and you don't have the bone findings, and this becoming aggressive and the behavioral problems. Pompei's has the cardiomegaly and hypotonia. Hunter's and Hurler's, if they give them to you together, they're going to have to give you something like corneal deposits or corneal clouding to be able to tell the difference between the two. Otherwise, you can't really on a first pass. And McArdle's is a glycogen problem in the muscle. So you see that muscle breakdown, elevated CPK, and myoglobinuria. All right, sphingolipidosis, Gaucher's disease. Type 1 is a non-neuronopathic form. Type 2 and type 3 both have neuro findings. Classic features include hepatosplenomegaly, thrombocytopenia, anemia, leukopenia, osteonecrosis, osteopenia, and pathologic fracture with an Erlenmeyer-Flax deformation. Again, types 2 and 3 have CNS involvement, and they're differentiated by the age of onset. They can have eye problems, apraxia, and nystagmus. You monitor for the known complications in the liver and spleen. Don't remove the big spleen. Use your enzyme replacement therapy. monitor for their bone involvement and pulmonary complications. Treat their current problems with liver dysfunction, thrombocytopenia, and control their pain. We've got enzyme replacement for type 1. If you catch them early enough, type 2, you can do bone marrow replacement. The most well-known of the sphingolipidoses is Tay-Sachs. It's autosomal recessive, and the incidence is about 1 in 100,000, so about 0.3% of the general population are carriers. It is enriched in the Ashkenazi population with 1 in 4,000, and 3% of people are carriers. It primarily affects the CNS, and it's caused by a deficiency of the alpha subunit of hexosaminidase A, and it gives you accumulation of a GM2 ganglioside in the neurons. There is a typical course where at 0 to 6 months, you get apathy and hypotonia. 6 to 12 months, you'll start to see the cherry red macula. The child becomes spastic and rigid. 12 to 18 months, drooling and seizures. 18 to 24 months, megaloencephaly, cortical blindness, quadriplegia, and then death with contractures, autonomic dysfunction at 2 to 4 years of age. We can do it make the diagnosis on an enzyme assay. If you're in a high-risk population, you can do DNA diagnosis for the 3 mutations that are responsible for 98% of Tay-Sachs in the Ashkenazi population. Some groups will do this and then do one of 2 things. Either have a matchmaker match you with somebody who's not a carrier, so you're not at risk for having a child with Tay-Sachs, or if you know that you're both carriers, and you can do prenatal testing. So it really depends on which community you live on and what your religious beliefs are, how you approach your status for carriers for Tay-Sachs. So again, this heterozygote screening in high-risk populations has reduced the frequency of Tay-Sachs by 95% in the Ashkenazi population. You're much more likely to see Tay-Sachs in somebody who is not of Ashkenazi descent simply because they know and they've been screening for it and they can tell you. So just because somebody is not of, quote, the right background, one of the children we cared for when I was a fellow, I think one parent was from Africa and the other parent was from Asia. So clearly not the right ethnic background, so keep it on your radar. Fabry's is another sphingolipidosis. It's X-linked. Carrier females are variably affected, again, based on this X inactivation. It's due to decreased or absent alpha-galactosidase, and it gives you progressive deposition of this GL3. The onset of symptoms is usually in adulthood. However, within normal limits, the WNL also means we never looked. So when you start actually looking, you can see childhood onset of these internal issues. And this is being added to newborn screening. Because of this, we can start to see the renal problems much earlier if we're looking for them. And we have an enzyme replacement therapy for it, so we can actually begin treatment and get better outcomes. The adults with these can have pain crises, especially of the hands and feet. There's a lack of sweating. These angiokeratomas, especially around the umbilicus, is the key feature. And you'll see it in clinic. You'll see it on every exam. You get end-stage renal disease in adults. And with the enzyme replacement therapy, you're hoping to avoid that by starting it early in the children. Metachromatic leukodystrophy is autosomal recessive. You're missing your aryl sulfatase A, and you get metachromatic deposits in the central and peripheral nervous systems and the visceral organs. Onset of symptoms can be infantile to adult. You get optic atrophy, progressive neurologic problems with loss of skills. So anytime you see developmental regression, that's bad. And then psychiatric disturbances. All right, so you're now seeing a 5-year-old female brought in for fatigue and pallor. Otherwise, her development and growth have been normal. Mom reports that over the past year or so, she seems to have less energy, and compared to her peers, she looks pale. She also seems to be gaining weight in her trunk, even though she eats healthy food and her mom tries to keep her active. On exam, she's a normal-appearing 5-year-old with pale conjunctiva and splenomegaly to the pelvic brim. Labs confirm anemia with lots of schistocytes, and X-rays show osteopenia. The diagnosis most consistent with these findings is And indeed, this is Gaucher's. So we got splenomegaly, and there's no other facial features. There's no coarsening of the features, and the osteopenia goes along with that. Fabry's usually affects the men, but women can also have problems with pain crises and the angiokeratomas. Hurlers, you could have normal development, but growth is usually short by this age, macrocephaly and coarsening. Niemann-Pick is severe and associated with ID as well as hepatomegaly. In Sanfilippo, you should be seeing loss of skills. All right, on to the peroxisomes. The peroxisomes are another set of organelles in all of our cells. They make an impermeable membrane to keep their functions very isolated because they're going to do some fun things in there. They're going to do fatty acid beta oxidation, so it catalyzes the very long-chain fatty acids, your bile acids, your branched-chain fatty acids, and your eicosanoids. They also do ether phospholipid biosynthesis, making plasmalogens, and this is an important part of your brain development. It also has catalase in there for degradation of hydrogen peroxide. It also does cholesterol synthesis. So a lot of things going on in your peroxisomes. Zellweger syndrome is a disorder where you don't make your peroxisome. So all of those enzymes that are supposed to live in your peroxisome have nowhere to go. So all of those functions are disrupted. So you look like you have a disease of every one of those things we just listed. So you're going to have multiple abnormalities on the lab tests that we send. These kids have a characteristic facial features. I think they look reminiscent of children with Down syndrome. So your first pass sort of looks like Down's, and then you start looking, and it's like that's not quite right. Large anterior fontanelle, cataracts, a pigmented retinopathy, epiphyseal stippling, liver function abnormalities, jaundice, and this spectrum includes neonatal adrenoleukodystrophy and infantile refsums as a progression of the spectrum. The children I've seen with Zellweger's, they are so hypotonic, they make the kids with Down syndrome look like bodybuilders. They are beyond hypotonic. All right, a brief assortment of other categories: leukodystrophy, purine metabolism, cholesterol, metal, and congenital disorders of glycosylation. All right, Canavan. It's autosomal recessive due to aspartyl cyclase deficiency, and it's much more common in the Ashkenazi population. Compare this to GA1, Tay-Sachs, and metachromatic leukodystrophy. All of them have macrocephaly. And here's the growth curve with this child. You can see this is absolute macrocephaly. They will have hypotonia and loss of motor skills between 2 and 4 months of age and then become spastic. They have optic atrophy, seizures, and your MRI will show demyelination. Lab findings include N-acetyl aspartic acid, or NAA, in the urine and plasma. Copper metabolism, there are 2 disorders. One is Menkes disease. It's X-linked recessive. There is no copper uptake into the liver, so there's deficiency of copper and copper metabolites. These kids have hypotonia. They don't make their milestones. They have kinky hair, so it's also known as Menkes kinky hair disease, and seizures. So this is the other condition where you call your friendly dermatologist in on a Saturday to pluck off a piece of some of the hair and go look at it underneath a microscope because you see a very particular pattern of the hair. The other copper metabolism problem is Wilson's disease. This is autosomal recessive, and you have too much copper. So you build up copper in your liver and brain. Clinical features: over time, you will develop Kaiser-Fleischer rings, psychiatric problems, and a progressive liver dysfunction. And you treat these people by giving them chelating agents to pull the copper out of the body. Lesch-Nyhan syndrome is a disorder of your purines. It's also X-linked recessive. It is due to a deficiency of hypoxanthine guanine phosphoribosyl transferase, or HGPRT. These people have elevated uric acid. So just like you do for gout, just send a uric acid and you'll be able to make your diagnosis. They may present at 2 to 3 years of age with self-mutilation, with biting fingers and lips. They have developmental delays. They can have chorioathetosis. They can make renal stones. They do get gout. Cholesterol biosynthesis problems, Smith-Lemli-Opitz syndrome. Autosomal recessive, 1 in 20 to 40,000 people have it. It's a deficiency in 7-dehydrocholesterol reductase. So this is also a cheap and easy test to send. May take a couple of days to come back, but look for your 7-DHC or 7-dehydrocholesterol. Your cholesterol can be normal or low. Your cholesterol is important in your embryogenesis. And so these people have dysmorphic features. And it was actually the first metabolic condition that was described where the child was actually dysmorphic, not in a way that the lysosomal storage disorders are dysmorphic. Because we often think of all of these intoxications and energy deficiency syndromes as being non-dysmorphic. These kids will give you a clue. So the treatment is dietary cholesterol and bile acid supplements. These can help the behaviors, but it doesn't really help the intellectual functioning. They can have microcephaly, introverted nares, ptosis, and a cleft palate. 2,3-toe syndactyly, but realize that lots of people have 2,3-toe syndactyly. You're looking for really all the way down to the end of the toe. Hypospadias, again, common in the general population, or ambiguous genitalia, and intellectual disability. So making sure there's some 2,3-toe syndactyly in the hypospadias could be common, but do you have more to go on than that? Congenital disorders of glycosylation is a relatively new group of disorders, and the list keeps getting longer by the week. It can affect any organ system, and it's a defect in glycosylation of molecules in the ER, endoplasmic reticulum, that's important for targeting a molecule. So you can't do N or O-linked glycosyl groups if you go back to organic chemistry, and those are the things we need on the outside of the cells for them to communicate with one another. So you have impaired communication cellularly. There are more than 40 forms. PMM2 CDG, which used to be known as CDG1A, is the classic one that was first described. It gives you cerebellar hypoplasia, a liver disease, inverted nipples, and abnormal fat pads on the back, right above the iliac crest. It is easy to screen for with the carbohydrate-deficient transferrin, though. All right, examining a 12-month-old male who has a 2-month history of developmental regression. During his first 6 months, he met all motor, language, and social milestones. On physical exam, his growth parameters are normal. He has poor eye contact and marked head lag. There's no organomegaly or other physical findings. Which of the following diagnostic test is the most appropriate? All right, so this is Tay-Sachs. So hexosaminidase A is what you're looking for. So knowing what each one of those is and being able to name the disorder is the important part. Glucocerebrosidase is Gaucher's, which would have been the hepatosplenomegaly anemia. 7-dehydrocholesterol is Smith-Lemli-Opitz. MECP2 is Rett syndrome. And the N-acetyl aspartic acid is Canavans. So again, they may not ask you directly what it is, but which test do you want to order? All right, we're down to newborn screening. What can we screen for on newborn screening? Intoxications, the amino acid disorders, some but not all, organic acidureas, and some of the urea cycle defects because you're getting abnormalities in your amino acids. Energy metabolism defects, the fatty acid oxidation disorders are perfect for this. Not identified on screening. Complex molecule defects. However, this is changing rapidly. Some of the LSDs now have been added to select states because we have enzyme replacement therapies. So this is an ongoing debate, and it's on state-by-state basis. So knowing what happens in your state and your bordering states will tell you what the child's been screened for. You really can't screen for the glycogen metabolism defects because it's going to present with the hypoglycemia. There's not an abnormal metabolite to go looking for. And then the mitochondrial defects are difficult as well because you may throw off abnormal metabolites with time, but they're not very consistent. So categories of newborn screening are selected inborn errors of metabolism. We can do enzyme analysis. We can do quantitation of amino acids and acylcarnitines. We can do hemoglobinopathies by protein electrophoresis, endocrine disorders like CAH and hypothyroidism, cystic fibrosis by immunoreactive trypsinogen and CFTR mutations. Newest on the list are these immune deficiencies looking for SCID with a TREC analysis, but again, you're going to start picking up some of the 22 Qs. We test for hearing with otoacoustic emissions or brainstem response. And many states have now added formally congenital heart defects with pulse oximetry. So it's more than just the blood spot card. Things that are enzyme tests, GALT for galactosemia, and biotinidase, which we did not cover in this, but it will cause biotinidase deficiency. If you're doing enzyme testing and your blood spot card gets caught in the desert or Dallas for a week, and all of your enzymes are now inactivated, and you have multiple enzyme deficiencies, ask where the truck sat for a week. True story. So if you're seeing more than one, it could be that somebody has more than one thing, but it's less likely. Repeat that test because the enzymes will become inactivated with heat. Results on fluorometric reading of the enzyme activity, and it's sensitive to time and heat. So if it hangs out for a week in the middle of the desert, not a good thing. The tandem mass spec can do 25 to 30 disorders on one blood spot. The runtime is about 1 to 2 minutes per specimen. It's sensitive and specific. Cost is somewhere around $10 per specimen. Amino acids and acylcarnitines, and then we interpret that based on that A to B to C pattern analysis. We do our acylcarnitines. That gives us fatty acids, fatty acid oxidation disorders, organic acidurias based on the acylcarnitine profile. Amino acids, the amino acid profile, and then we can pick up some of the urea cycle defects. All right, high yield things. Be familiar with presentations for PKU, homocystinuria, maple syrup urine disease, urea cycle defects as a group, galactosemia, glycogen storage diseases, MCAD, MPSs, and Zellweger. Know that these things equal one another. Succinyl acetone is tyrosinemia type 1. Alloisoleucine is MSUD. In utero hiccups is non-ketotic hyperglycinemia. Trichorisis nodosa is arginosuccinic aciduria. GALT is classic galactosemia. E. coli sepsis is classic galactosemia. Acid maltase and pompase, hexosaminidase A and Tay-Sachs. 7-DHC, Smith-Lemli-Opitz, Kaiser-Fleischer rings, Wilson's disease, and kinky hair, Minky disease. So know the two that you have to call your dermatology friends on the weekend. All right, clues that it can be a metabolic disease, an anion gap with metabolic acidosis, hypoglycemia with ketones, without ketones, and with or without hepatomegaly. If it's a respiratory alkalosis, look at the ammonia. If there's ever a loss of skills or regression, that is bad. Think about metabolic diseases, and if there's organomegaly. And we are done for this section.